Good morning, everyone. I am Dr. Almas Vakil, today presenting a case on safe wear under the guidance of Dr. Tarun Ojha sir. I am presenting a case of patient Sonu, a 14 years old Hindu male residing at Malpura, who is a student coming from middle socio-economic class, came to ENT OPD with chief complaints of left ear discharge since 5 years. Importance of asking name is for identification of the patient, for developing rapport, for maintaining the record of the patient, and for knowing the unknown religion. Importance of ages. AOM and OME are more commonly seen in children. Autosclerosis is more common in puberty. Carcinomas, presbyculosis, benign paroxysmal position vertigo is more common in old age. Importance of asking sexes. Females have more commonly autosclerosis and Meniere's disease. Males have more commonly carcinomas, AOM, and OME. Importance of asking address. Those residing near airports and railway tracks can develop noise-induced hearing loss. Modified Kuppuswamy classification is degrading to classify according to economic classes. It includes 3 headings: education of the head of family, occupation of the head of family, and total per capita income. Based on this, it gives scores. After calculating the scores, it divides into 5 classes, that is upper class, upper middle class, lower middle class, upper lower class, and lower class. Importance of asking religion is consanguineous marriages leads to higher incidence of congenital SNHL. Importance of asking occupation. The factory workers can develop noise-induced hearing loss. History of present illness. Patient was apparently asymptomatic 5 years back. Then she developed complaint of left ear discharge, which was insidious in onset, moderate, yellowish, mucopurulent, not bloodstained, and foul smelling. It was associated with pain in left ear. It was intermittent and relieved on taking medications. Patient also complained of left ear reduced hearing since 1 year, which was gradual in onset and progressive in nature. It was not associated with tinnitus, pain, or earfulness. There are no complaints of tinnitus, ear pain, headache, vertigo, or facial palsy. No complaints related to nose or throat. Discharge. Mucoid discharge is seen in OME, AOM, COM. Mucopurulent discharge is seen in AOM, COM. Watery discharge in CSF otoria. Bloodstained discharge is seen in trauma, aticoantral disease, granulation tissue, malignancy. Foul smelling smell seen in aticoantral disease and when there is infection. Non-foul smelling is seen in tubotympanic disease. Consistency of the discharge. Mucoid discharge is the characteristic of middle ear. Color. Yellowish discharge is seen in purulent. Venous discharge is because of Pseudomonas infection. Quantity. Scanty discharge is seen in aticoantral disease. Moderate to profuse is seen in tubotympanic disease. Deafness. Conductive deafness is defect in the conductive mechanism of external or the middle ear. Sensory neural deafness is lesion in the labyrinth, cochlea, the 8 nerve or higher pathways. Mixed deafness means both conductive and sensory neural components are present. A gradual loss is seen in chronic suppurative otitis media. Sudden is seen in fracture of temporal bone. Fluctuating means mean is seen in Meniere's disease and perillant fistula. With vertigo is seen in Meniere's disease. Tinnitus. Bilateral tinnitus is seen in autosclerosis. Unilateral is seen in acoustic neuroma. With vertigo is seen in Meniere's disease. With deafness is seen in Meniere's disease. Pain. AOM has a characteristic sharp, throbbing, and lancinating pain. Furunculosis has a dull, throbbing, and continuous pain. Pain at the tragus is seen in furunculosis. Deep pain inside the ear is seen in acute suppurative otitis media, traumatic perforation, or in tumors. Referred pain is from the tongue, the tonsils, the teeth, the temporomandibular joint, and the throat. Vertigo. Its presence indicates intracranial complication in CSM cases. With deafness is seen in Meniere's disease. Without deafness is seen in vestibular neuronitis. Position. The vertigo is seen in benign positional paroxysmal vertigo. Facial palsy. In an unsafe ear, cholesteatoma causes facial palsy. With no ear discharge history and intact drum is characteristic of Bell's palsy. With vesicles in the external auditory canal and over the pinna is seen in Ramsay-Hunt syndrome. Facial palsy with deafness is seen in acoustic neuroma. Headache means there is a complication such as brain abscess, lateral sinus thrombophlebitis. Past history. No history of diabetes mellitus, hypertension, ischemic heart disease, tuberculosis, asthma. These are relative contraindications to surgery. no history of blood transfusion, no history of previous surgery, or history of drug allergy or drug intake. Now, in patients having diabetes and hypertension, sensorineural hearing loss is seen. Diabetic mellitus also leads to automycosis. Tuberculous otitis media is seen in patients having tuberculosis. Personal history. The patient takes a vegetarian diet with normal appetite, with normal bowel and bladder habits, with adequate sleep and nutrition. There is no significant family history, certain systemic diseases, and leads to hearing loss. General examination. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is well-built and well-nourished. No pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema is seen. Her blood pressure is 130 by 80 millimeter mercury in right brachial artery in setting position. Pulse is 80 per minute, regular in rhythm, rate, and volume in right radial artery. Respiration rate is 20 per minute, thoraco-abdominal time, and she is afebrile on touch. Systemic examination, cardiovascular system examination, S1, S2 are normal and no murmurs heard. Respiratory system examination, bilateral air entry is equal, no additional sounds heard. Central nervous system examination, higher mental functions are normal. On per abdominal examination, it is soft, non-tender, no guarding or rigidity is present, no organomegaly is present. Significance of general examination in the case is it is done for proper diagnosis and differential diagnosis and for selection of the patient for anesthesia to decide the type of surgery and to predict prognosis. Mental status and level of consciousness should be assessed in general, but in particular in specific clinical situations like head injury, hepatic encephalopathy, septic shock, etc. This is the Glasgow Coma scale that includes three responses, that is eye-opening, verbal response, and motor response. And based on the responses the patient gives, it scores, and a total of score is calculated. Now, Glasgow Coma scale is important in intubated patients because patients who are intubated are unable to speak and their verbal score cannot be assessed. They are evaluated on the basis of eye-opening, motor scores, and suffix C is added to their score to immediate intubation. In intubated patients, the maximum Glasgow Coma scale score is 10T and the minimum is 2T. Now, build and nutrition status. Build is the structure and organization of underlying skeleton. It is related to age and sex of the patient. In normal adults, the height of the build is structural organization of underlying skeleton. It is related to age and sex of the patient. In normal adults, height of the person is equal to length of arm span. Upper segment from vertex to pubic symphysis is equal to lower segment from pubic symphysis to heel. In infants, upper segment is more than lower segment and height is more than arm span. Nutrition is proportion of soft tissue structures in relation to bony structures. Protein deficiency causes rough skin, brittle hair, and edema in the feet. Fat deficiency causes cachexia, hollow cheeks, loss of fat in hips, abdomen, and subcutaneous tissues of elbow. Pallor is checked in lower palpebral conjunctiva, mucous membrane of lips and cheeks, nail beds, and palmar creases. Causes for pallor in this will be massive bleeding, shock, dysphagia, throat carcinomas, neuropharyngeal angiofibroma, and deficiency anemia, Plummer-Vinson syndrome, and atrophic rhinitis. Icterus. It's due to deposition of white pigments with excess of it and plasma. It is checked in upper sclera, better seen against white background, asking the patient to look at his feet, and clinician puts the upper eyelid upwards. It also can be checked in nail bed, ear lobule, nasal tip, and on the surface of tongue. Cyanosis. It is due to rising level of reduced hemoglobin in the blood, causing blood fluid or purple discoloration in the skin and mucous membrane. A minimum of 5 grams per deciliter of reduced hemoglobin should be present in the circulation to cause cyanosis. Peripheral cyanosis is checked in nail bed, palm and toes, tip of the nose. Tongue is not involved in peripheral cyanosis. Central cyanosis is confirmed by checking in tongue, nail bed, palms, and toes. Cyanosis is seen in foreign body's bronchus, lung collapse. Edema. It's the collection of fluid in the interstitial spaces or soft tissues. Edema will be clinically evident only when fluid accumulates more than 5 liters. Sitting on pressure is the cardinal sign of edema. Conditions in ENT with edema are myxedema, angioneurotic edema, cachexia in malignancy, liver metastatic carcinoma, metastatic lymph nodes, pressing on lymphatics. Lymphadenopathy. Cervical lymphadenopathy is seen in infections and tuberculosis and carcinoma as secondaries. Pulse. Normal pulse rate is 60 to 100 per minute. Tachycardia means increased pulse rate. It is seen in anemia, fever, sepsis, severe pain, shock, and toxic thyroid. Bradycardia is decreased pulse rate, less than 60 per minute. Blood pressure. Hypertension is persistent rate systolic blood pressure more than 140 mmHg or diastolic less than 90 mmHg. It's situated sustained elevation of systemic arterial pressure. It is seen in raised intracranial tension, thyrotoxicosis. Hypotension is diminished blood pressure, that is systolic pressure less than 90 mmHg and diastolic pressure less than 60 mmHg. It is seen in a cachexia or malignancy, tuberculosis, anemia, functional causes. Respiration. Tachypnea means respiration rate more than 20 per minute. It is rapid breathing seen in fever, shock, hypoxia, acidosis, tetany, hypo or hyperthyroidism that stresses high hysteria. Gradual deepening of respiration alternating with short periods of apnea is called clean strokes respiration. Fever or rise in temperature. Normal temperature is 36.7 degrees Celsius to 37.5 degrees Celsius or 98 to 99 degrees Fahrenheit. A diurnal variation of 1 degree Celsius is normal. Lowest temperature in morning 2 to 4 am and highest being in afternoon. Fever is increase in body temperature more than 1 degree Celsius or more than the maximum range. Sites of measurements are oral, axillary, or rectal. Causes for fever could be infective, bacterial, viral, fungal, parasitic, or CSM with intracranial complications, ASOM, acute mastoiditis, neoplastic, traumatic, thyrotoxicosis, infection, mononucleosis, infections like diphtheria, tonsillitis, Vincent's angina, herpes labialis. Local examination. Under bull's eye lamp, head and mirror examination, the pinna, the preauricular region, postauricular surface, and external auditory canal of the right and left ear were normal. The tympanic membrane of the right ear was normal. Left ear tympanic membrane had a single medium-sized circular perforation, the central perforation in the pars tensa. This is the right tympanic membrane, which is having a normal appearance. The left tympanic membrane had, as I said, a circular single medium-sized perforation in the pars tensa, pars flaccida being normal. This is the diagrammatic representation of the right ear and the left ear tympanic membrane. In the diagram, you can see the right ear tympanic membrane, your normal parts are being labeled, such as pars flaccida, pars tensa, the handle of malleus, the cone of light, the short process of malleus, and the anterior posterior malleolar folds. And this, in the left ear, is the perforation which is seen. Middle ear mucosa in the left ear is pale. Facial nerve examination is normal on both sides. No nystagmus is present on both sides. Large pinna is seen in macrotia, small pinna is called microtia, absence of pinna is anotia, absence of NTLX is bad ear, follicular ear is seen perichondritis. Preauricular region shows a preauricular sinus or an accessory tragus. Postauricular region may be having a scar, may have edema, just mastoiditis, postoral fistula, or postoral lymph node. Postauricular sulcus is obliterated in mastoid abscess. Protrusion of the pinna is seen in mastoid abscess and furunculosis. Tenderness over the mastoid region is seen in mastoiditis, over the pinna is seen in perichondritis, and over the tragus is seen in furunculosis. Now, the external auditory canal may have either a wax or a furunculosis, a fungus, or a keratosis of furans or otitis externa of the external auditory canal. Tympanic membrane may be congested in ASOM, tail may be seen in otitis media with effusion. A perforation may be seen, which may be central, marginal, or antic. There may be a single or multiple perforation. It may be either total or subtotal. Tuning fork test. Now, it was done using 5 and 2 Hz tuning fork. Rennie's test was positive on right side and negative on left side. Weber's test was lateralized to the left ear. Absolute bone conduction tests were equal on both sides. This is the tuning fork, which is having prongs, base, shoulder, and a stem. Positive Rennie's test is when the patient hears the vibrations of air conduction better than the bone conduction. KC is better than BC. It is seen in normal subjects and patients with sensory neural hearing loss. Negative Rennie's is when the patient hears the vibrations of bone conduction better than the air conduction, that is, bone conduction is better than the air conduction. Now, conductive deafness when the hearing loss is more than 15 decibels, negative hearing loss when Rennie's is seen. False negative Rennie's is when Rennie's test is negative in the affected ear, but Weber's test is not lateralized to the diseased ear rather than lateralized to the better ear. It is seen in severe unilateral deafness. Equal Rennie's, that is, air conduction and bone conduction, are heard in equal intensities, is seen in mild conductive deafness. Infinite Rennie's is if patient hears only air conduction but no bone conduction. Weber's test. Weber's test, it becomes lateralized in the affected ear in conductive deafness when hearing loss is 5 decibels or more. Sensory neural deafness, it is lateralized towards the better ear. Absolute bone conduction test. ABC is reduced in sensory neural hearing loss. It is not reduced in normal ear and conductive deafness. Nose and panels of sinuses. External examination of nose was normal. Skin over the nose was normal. Nasal vestibule, the septum, mucosa, floor, cavity, and turbinates, inferior turbinates, and meatai were both anterior two-thirds of tongue, gums and teeth, floor of mouth were normal. Oral pharynx, bilateral base of tongue, uvula, soft palate, anterior pillar, posterior pillar, tonsils, posterior pharyngeal wall were normal. Bilateral vocal cords are mobile and laryngeal crepitus was present. Examination of neck, no cervical lymphadenopathy was seen or no swelling was seen. My provisional diagnosis will be left chronic otitis media with active mucosal disease with mild conductive hearing loss. Investigations that I'll undergo is pure tone audiometry, X-ray, both mastoid and Schuller's view, fast for cultural and sensitivity, routine hematological and biochemical investigations, COVID-19 RT-PCR and HRCT test for ruling of COVID-19 infection, and X-ray test EAV. X-ray master Schuller's view. See, repetitive cellular air cells are large and numerous. In diploid, air cells are small and less numerous. Narrow spaces present. Sclerotic means cells and narrow spaces are absent. About 80% of mastoids are pneumatic and 20% are sclerotic. Management. Oral toilet, that is dry mopping, taking a dry ear swab stick and mop off discharge. Ear swab for culture and sensitive to take the swab from the discharge at the deeper part. Broad spectrum antibiotics such as ampicillin or amoxicillin till culture and sensitivity report comes. Afterwards, start the antibiotics reports. Common organisms such as H. influenza in children and Staphylococcus aureus and Streptococcus in adults are seen. Local antibiotic ear drops. First, clean the discharge, instill the ear drop in the ear, and press the trachea repeatedly. Systemic antihistamines like levocetirizine can be started. Local decongestant nasal drops such as xylometazoline nasal drops having local decongestant effect on the eustachian tube. Protection of the ear from water. This is important. Patients should put cotton swab impregnated Vaseline or glycerin or any edible oil to prevent the entry of water inside the ear during bathing. During swimming, the ear plugs. Treat the septic foci. Usually, the septic foci are in tonsil adenoids in children and nose and adults. In adults, it is sinusitis. DNS may lead to sinusitis. Tympanoplasty, that is surgery, is done when the ear is dry. There are Wilson defined the types of tympanoplasty as follows. Type 1 tympanoplasty is when there is defect of perforation tympanic membrane. Here the graph lies on the tympanic membrane for malleus. Type 2 tympanoplasty is when perforation of the tympanic membrane is present along with erosion of malleus. The graph lies either on the incus or remnant of malleus. Type 3 tympanoplasty is when malleus and incus are absent and the stapes suprastructure are present and graph lies on them. Type 4 tympanoplasty is when stapes suprastructure also absent and the graph lies here on stapes footplate. Type 5 tympanoplasty is when stapes footplate is fixed. Here a fenestra in horizontal semicircular canal is created. The instruments that will be used in tympanoplasty will be ear speculum seen on the left side over here, the mollusc and self-retaining hemostatic mastoid retractor. Then the general instruments such as stall clip, Burn stall clip, the sponge holding forceps, the Mayo stall clip, the mosquito forceps, and the BP Bard Parker knife handle, the artery forceps, the landing bag retractor, Paragos periosteal elevator, the sickle knife, the Shia's knife, circular knife, that is Roseanne's knife, and the Cotron micro ear curved pick, the microsurgical scissors, Baluchi scissors, the cut forceps, that is the Wolstein forceps, microsurgical forceps, and the needle holder. This is the unicortal cautery that will be used. Coming to the question and answers, what are the various methods to know the patency of eustachian tube? These are the Balsai's method, the Toynbee test, the Pulitzer's method, the eustachian tube catheterization. Dr. Kanika asked, what is tympanosclerosis? It is white place in the tympanic membrane and surrounding ossicles due to hyaline degeneration leading to calcifications. What is adhesive otitis media? The entire tympanic membrane is thin out due to degeneration of the fibrous layer and adhesion is formed between the membrane, middle layer, and ossicles. When is false positive fistula test seen? It is seen in congenital syphilis. How is mobility of the tympanic membrane tested? It is tested either by Balsai's method or Seeger's pneumatic speculum, that is sigillization. What is the central perforation? It is a perforation in the pars tensa and is surrounded all around by the tympanic membrane. What is the furunculosis? It is staphylococcal infection of the air follicles of sebaceous glands present in the skin of autocartilaginous part of the external auditory canal. What is the area of tympanic membrane? The total area of tympanic membrane is 90 square millimeters. How is cholesteatoma classified? It is classified either as congenital or acquired. Acquired may be primary or secondary. Thank you.